some many times. So this lecture should be more of a review for you guys. But the main components of the circulatory system, of course, is the heart, which pumps the blood vessels which carry the blood, or the blood travels through, and then the blood itself, right? So that's the entire circulatory system. Number one. Of course, your arteries carry oxygen-rich blood away from the heart, except for which artery? Let's see, Seth, which artery does not carry oxygen-rich blood?
That would be the veins, right? The vena cava.
No, so it says so arteries always take blood away from the heart,
Yeah,
and every single artery. So arteries and veins are two different things. So
the
every
arteries. Okay.
yeah, which one? Do you know which one?
Wouldn't it be the? It goes from the heart to the lungs, right?
Yes, exactly. So
The
it's called the
pulmonary artery.
there you go, exactly. Pulmonary artery. So the pulmonary artery carries oxygen, I mean, not oxygen, blood from the right ventricle to your lungs. And that blood is actually high in CO2, carbon dioxide, and low in O2. And it takes blood away from the heart to the lungs to get oxygen. So your arteries are thicker, and they have muscular walls. And the reason for that is because they need to be a lot stronger than veins do because of the pressure behind that left ventricle. Every time it contracts, it creates a lot of pressure. So these vessels, the arteries, need to be thicker and more muscular. The capillaries, this is where arteries and veins meet. So they meet at the capillaries, and capillaries, we find them around the alveoli and also around pretty much every single cell in the body or tissue in the body, I mean. And that's where gas exchange occurs. At the alveoli, the gas exchange between the alveoli and the capillary is where the O2 is being picked up by the red blood cells inside the capillaries to be taken to the tissues at the body. So once that blood reaches the tissues, the capillaries that are at the tissues of the body, that O2 is then dispelled or let go to feed the tissues, and then the CO2 is picked up and taken back to the heart and the lungs. But the capillaries is where both the veins and the arteries meet, both in the alveoli and tissues, and that's where gas exchange occurs. Your veins, talked about them. So they carry oxygen depleted blood, meaning that it's not very high in oxygen, it's poor in oxygen, but rich in carbon dioxide. And this blood is being carried back to your heart to get oxygen to then feed the tissues of the body. The only vein that does not carry oxygen poor blood is the vein that travels from the lungs to the left side of the heart, because that blood is coming from the lungs, which already has oxygen, because it went to the lungs to get oxygen. When it leaves the lungs, it goes to the left side of the heart, full of oxygen, to then be pumped to your body and the tissues of your body. Perfusion. If you don't know these by now, please write them down. I will give you a few seconds. Perfusion means that everything is working the way it is supposed to be working. Your body is functioning adequately if you have good perfusion. That means the blood is getting to where it needs to go. Not only that, but the blood is carrying the oxygen and the amount of oxygen that is needed to feed the tissues of the body. So that is what perfusion really is. Hypo means low. So if we have hypoperfusion, that means that we have low perfusion, which means that not enough oxygen is getting to where it needs to go, okay, to the tissues. Why that is could be a number of reasons. And that's where the different classifications of shocks come into play, okay? Because there's different ways of becoming hypoperfusion, and that's the reason that we have different kinds of shock, because there's different ways of getting shock. Hypoperfusion, if it continues, is shock. It eventually equals shock. It will turn into shock. Any questions? If you do, please ask. Nope. All right, so now we're going into bleeding. So we have three different types of vessels, right? We have the arteries, we have the veins, and we have the capillaries. That means that we have three different types of vessels, which means that we have three different types of bleeding, of ways to bleed. Hemorrhage is severe bleeding. So every time you hear hemorrhage, hemo, hema, anything that is hem something in the medical field is going to be about blood, all right? Hemorrhage just means a lot of blood. You're bleeding a lot. Major cause of hypoperfusion and trauma. So obviously trauma situations, you're going to have physical damage, right? If you have physical damage to the vessels, you're going to have bleeding. External or internal, I've always used different examples for external. It would be like getting your arm chopped off with a samurai sword. You're going to bleed out, right? Internal bleeding would be playing baseball with little Timmy. Little Timmy hits you in the stomach with a baseball bat because you made little Timmy mad, but the skin is intact, but that ruptures an organ or a vessel inside the stomach. Now you have internal bleeding. That's internal hemorrhage. See, patient was in a car accident. They are showing signs of shock with no visible bleeding. What should you suspect? Michaela, what should you suspect with this patient? What's going on? You there, Michaela?
Can you hear me?
Yeah, I can hear you now. So this question, so what's going on with this patient right here? This question in the bottom.
Internal bleeding.
Perfect. Yes. If there is a trauma situation and you pull up to a trauma and the patient has signs of shock, we're always going to assume it's internal bleeding, because if we can't see why the patient is declining and it's a trauma situation, the only thing that really makes sense is internal bleeding, unless there's an underlying medical reason that we can't find. Okay? All right, so here are your different types of bleeding. So arteries, they spurt blood because every time that left ventricle contracts, it pushes that blood outward. And if there's a cut along the arteries, that blood is going to squirt out with every contraction of that heart. Every time that heart contracts, blood comes out. Blood comes out. Pulsating flow, and then it's bright red because of the oxygen when it attaches to the red blood cell. There's a protein in it, things like an iron protein, and because of that, it turns red. Just like how iron and metal rust, it gets like a brownish red, kind of the same concept. Veins are going to be a steady flow because so let me back up a little bit. The heart pushes blood through your arteries, right? So blood is traveling through your arteries, and the force behind that is the heart. After a while, the arteries become arterioles become capillaries, and in the capillaries, there is like a pause of blood because that's where the gas exchange is actually occurring. So if you have a scrape or a very minor cut, and it's only affecting the capillaries, you're gonna have a little ooze. It's like an oozing flow. So like a slow flow, oozing. That's the best way to explain it. After your capillaries, the blood is gonna go to your heart via the veins. So the veins carry blood, and it's pressurized with these little valves. So your veins have little valves along the way, and they're one-way valves. So there is no backflow. If the blood was to try to go backwards, the valves would shut because it's like a hinged door where it only opens in one direction. So it's gonna be a steady flow, but those valves themselves create enough pressure to create a good sustainable flow of blood. External bleeding, that's pretty self-explanatory. Occurs outside of the body after force penetrates the skin or lacerates. Penetrating means that something went through the body or through tissue. Laceration or lacerate, if you don't know this, write this down. Lacerate is a fancy word for a cut. It just means a cut. or destroys underlying vessels. See, typically visible on surface of skin. See how much a person bleeds determined by size, severity, size, pressure. Okay, you know that. Massive hemorrhage. So I already talked about this. I'm not gonna hit it up again. I went over all this in that one slide. So it's talking about arterial bleed and everything that I already went over. Venous bleeds. Obviously, the one thing that I did not cover was the fact that venous blood is gonna be darker than arterial blood, and that's because of the lack of oxygen in the blood. Capillaries is gonna be more of a oozing. This right here is a good oozing. Write that down if you don't know that. And it could be dark red or bright red. That one doesn't. Other external hemorrhage, bleeding can be accelerated by underlying conditions. So like blood thinners, prescription medications, blood thinners is one of them. Hypothermia affects body's ability to clot. So the clotting cascade that I mentioned, I think in the last lecture or the last PowerPoint, that clotting cascade is this. That phrase means all the steps that are needed to create a clot. The clotting cascade are the steps needed to create an actual clot. And I'm talking about a scab. And what it's talking about is talking about the activation of platelets and then the activation of those clotting factors. Well, if your patient is hypothermic, meaning they're cold, hypo, low, thermia, temperature. So the temperature is low, it slows down the clotting effect. So if your patient's in a cold environment, they're not gonna scab as easily as someone that's in a more of a warm environment. That's what that means. So you must use standard precautions, obviously. So standard precautions, that means BSI, body substance isolation. Use your gloves, use your goggles for bleeding. You don't want to get this stuff in your system because you don't know what your patients have. Especially in a trauma situation, that's different than a medical situation. In a trauma situation, you're going for trauma. You're not going for medical, so you don't really know this patient's history. If you roll up on a medical call, usually you have time to get a full medical history of the patient, understand what they have, what medications they're taking. In trauma, it's a different game. So always use standard precautions. Ensure adequate breathing, obviously, for this patient. See, control bleeding only after assessing and treating prior elements. So what that means is that if the bleeding is not severe, if the bleeding is not life-threatening, then don't let it take priority. Don't get that tunnel vision, because we need to make sure that our patient is still breathing, the airway's patent, and we have to make sure that they're breathing adequately. If they're not, we gotta take care of it. So we can't get that tunnel vision. So for example, if the patient has a very nasty chunk of flesh on the forearm, right? But it's not actively bleeding and they have pressure on it, I'm not gonna let that completely take all of my attention, even if it looks nasty like hamburger meat, okay? First, I need to just take a quick second, look at my patient visually in my primary assessment, make sure they're stable or unstable, and then act appropriately after that. So be aware of signs and symptoms of shock. What are they? Why? And I think we talked about that plenty in this class, to where I don't really have to go over it unless somebody wants me to go over the signs and symptoms of shock. Nope. Okay. So use direct pressure, elevation, hemostatic agents, tourniquets to control bleeding. So when it comes to controlling bleeding, it's a sequence. It's a step like anything else. It's a procedure. The very first thing we do for active bleeding is we're going to apply direct pressure. All right, it's the very first thing we do. If it's a limb, we're going to elevate that limb above the heart to reduce blood from leaving the body, because the whole idea behind this is that if you elevate it above the heart, gravity will help you in a little bit. I'm pretty sure it's not even that much of help, but that's the idea behind it. Hemostatic agent. So hemostatic agent, it's a dressing. So you have just regular sterile dressings, and then you have hemostatic dressings. And hemostatic dressings, what they do is that they take away the fluid part of the blood, the plasma, and leaves all the solid stuff in the area to help clot faster. So it just kind of soaks up all the fluid, leaving all the dry stuff to kind of just seal off the injury a lot better. Now, if any one of these do not work, your last resort is going to be a tourniquet. And there's actually a slide for each one, and I'll talk more about the tourniquet when I get to that one. All right, so direct pressure, apply firm pressure, and we're always gonna apply pressure for at least 10 minutes or until the bleeding stops. So if you don't know that, I would write that down. For bleeding, we're gonna apply direct pressure for at least 10 minutes or until the bleeding stops, and that's for your normal dressing, the normal sterile dressing, not the hemostatic agent dressing. Once bleeding is controlled, bandage a dressing firmly in place. So once the dressing is there, you got a dressing, you apply direct pressure with the dressing, you never remove that dressing. You can put dressings over that one, but you're never gonna take that one away. And the reason for that is because once you apply that dressing onto your patients, the wound, it's going to start drying and getting stuck to the tissue. If you rip off that bandage, you're going to make it worse. You're going to take out any clotting that has already formed and possibly tear off more tissue and cause more damage. So never ever remove a dressing, obviously unless everything's situational. But if there's no special reason to take off that dressing, do not take off that dressing. It says here, when controlled, check for a pulse distal to the wound. Make sure dressing has not been applied too tightly. So just like anything else, after you splint something, you dress something up, we always want to make sure that the patient still has a pulse in the distal part of that limb. Direct pressure, place several gauze pads on wound as necessary. It's all situational. See, hold dressing in place with self-adhering roller bandage. And all these things, as far as like patient wounds and patient care, we're gonna go over this stuff when I see you guys in person. We're gonna hit this hard as far as like the actual practice of it, because just talking about it is not gonna be enough. But we'll definitely hit this up a lot more when we see each other in person, which should be sometime next month. See, controlling external bleeding, talked about elevation. Hemostatic agent designed to enhance direct pressure's ability to control bleeding. So usually for your hemostatic dressings, it's about 3 minutes. So if you don't know that, I write that down. So it's about 3 minutes for hemostatic dressings or until bleeding is controlled. Okay, as to where for regular dressing, regular sterile dressings that have nothing in them, nothing embedded, it's 10 minutes or until the bleeding stops. Okay, and the tourniquet is used as a last resort. And if the cut is right here, you want to put that tourniquet at least 2 inches above the wound. Okay, at least 2 inches above the wound. Now, right here, it looks like this patient has a cut right below the elbow, so the elbow should be right here. You do not ever want to put a tourniquet over a joint because it will come loose from movement. So if the injury, if the cut is here and a joint happens to be approximately 2 inches above the site, we're going to go 2 inches above that joint. Okay? So 2 inches above the actual site. If there's a joint located above the site, then it's going to be 2 inches above that joint. If for some reason this tourniquet does not work, you have the option of putting a second tourniquet right over the first tourniquet. So you would put the tourniquet here above the first tourniquet. Other options, of course, splint a limb in place. So if you have a broken arm or a broken leg and the bone is protruding out, a bone is never going to cut smoothly. It's always going to be jagged. So if you don't splint that bone in place, sometimes it will cause more damage. So that's one way that splinting does help with bleeding. Other options are your cold pads. So if you put a cold pad on a patient, the idea behind this is that cold temperatures constrict blood vessels. So if the blood vessels are constricted on the site or around the site, less blood will rush to that area. That's the idea behind that. Okay, so with this head injuries, with a head injury, you don't want to put direct pressure on a head injury. And the reason behind that is that if your patient has an open wound, right? They're bleeding from their head, and let's say they got, I don't know, let me just make something up. They got hit in the head with a golf club, right? And if the force behind that golf club was strong enough to actually break the cranium, the skull, crack it, and expose your brain, and if you start to bleed out from that wound, and so once you have that injury there, from that impact, you're gonna cause physical damage from the actual impact of the object going into the head. The aftermath is what worries us. So what happens after that? Every time there's an injury in any side of the body, it's gonna produce swelling and bleeding. Well, the head, the cranium being an encapsulated area in space, if you were to apply pressure and seal that wound, now what you're doing is you're allowing for all this fluid and blood to build up in the cranium, and that's gonna allow a lot of pressure to build. That pressure itself is gonna cause more physical damage, and that pressure on top of that is going to make the vessels constrict. It's gonna push down the vessels, which prevent blood from entering the brain. So this is the only time when you want to be very careful and not really apply direct pressure. For a head injury that is actively bleeding, you want to, if you have to, you want to apply gauze very lightly and loose on the head, and it's really just gonna be to absorb the blood that's coming out. That's really what it's for. It's not really meant to keep the blood inside, because we don't want to cause intracranial pressure. That's really bad for the patient. So epistaxis, if you ever hear this word, this will come up on the NREMT. I know I've seen it 2 times. Epistaxis, just know that it means nosebleed. Once you know what this means, you'll know how to go about it. And the treatment for this is the exact opposite of what grandma usually told you. So you don't want to lean back and put your head back. You actually want to lean forward, apply pressure to your nose, and that's pretty much it. Have the patient sit and lean forward, apply direct pressure to fleshy portion of the nostrils, keep patient calm, and that's it. You do not want to lean back or lean your head back, because that could actually allow blood to backflow into your GI tract and possibly asphyxiate the patient, given the situation, obviously. I think we talked enough about bleeding, internal bleeding. So I'm gonna play this video for you guys real quick.
Evaluation of circulation forms a critical part of your initial assessment. If blood is not adequately circulated, some of the cells and organs in the body will not receive an adequate supply of oxygen, and dangerous waste products will begin to build up. If the problem is not corrected, shock will occur. Severe bleeding or hemorrhage is one of the most common causes of shock. Signs of shock include restlessness or anxiety, pale, cool, and/or clammy skin, nausea and vomiting, tachycardia and tachypnea, and as a very late sign, hypotension. Take BSI precautions. This is important because there may be direct contact with possible blood-borne pathogens. Use gloves and goggles at a minimum, a gown for gross hemorrhage, and a mask or face shield for spurting blood. Expose the wound and estimate the amount of blood lost by the patient. Apply firm direct pressure to the wound with a gloved hand and gauze pads or other dressing material. Bleeding from a neck or chest wound should be controlled with an occlusive dressing that prevents any air from entering the wound site. Occlusive materials include any non-breathable substance, such as a gloved hand, Vaseline gauze, or plastic wrap. If bleeding is controlled and does not seem to be seeping through the bandages or coming up through your fingers, then bandage the dressing in place with roller gauze, elastic bandages, triangular bandages, or cravats. To ensure uniform contact and pressure over the wound, wrap a pressure dressing from distal to proximal. Assess distal circulation to ensure that the bandage was not applied too tightly. The intent is to maintain control of the bleeding with continued pressure. If firm, consistent, direct pressure fails to control the hemorrhage, a tourniquet should be applied. A tourniquet can be any material 2 to 4 inches wide that can be wrapped tightly around the extremity, but commercial devices are the most successful tourniquets because they have a built-in windlass that allows for proper tightening and continued constriction of the band. Apply the tourniquet at least 2 inches above the wound site and tighten as much as possible. Twist the windlass until bleeding has stopped and distal pulses are no longer palpable. If the tourniquet is not applied tight enough, it will actually increase venous bleeding, similar to when a constricting band is applied for blood draws or IV initiation. For very large or muscular patients, 2 tourniquets placed next to each other may be required to control hemorrhage. Secure the windlass in place with a strap that covers the windlass, ensuring it will not release the tension you have already applied. Document the time the tourniquet was applied. Some systems want this information literally marked on the patient's forehead so as not to be missed. Now that the hemorrhage has been controlled, you can begin to treat for shock. Appropriate treatment for shock includes properly positioning the patient supine, maintaining the airway and administering high-flow oxygen, reassuring the patient to reduce anxiety, and preventing heat loss by applying a blanket. Prepare the patient for transport and monitor vital signs.